What options do we have, both surgical and non-surgical, for this patient? If I recollect correctly, angle of MCP, which is more than 30, forms an indication for surgical release. And obviously it is a very subjective thing. The main decision making would depend on the clinical manifestations and complaints of the patient, as you rightly said. So what options do we have, both surgical and non-surgical, for this category of contracture, wherein the angle is maybe around somewhere between 20 and 30?
The patient can be advised collagenous injections, in which
so we will talk about non-surgical first.
Yes, sir.
Collagenous injections.
So about collagenous.
No.
Non-surgical
Modalities.
Non-surgical modalities, sir. We can give early on. We can give splintages to the fingers, which give progressive distraction, and subsequent follow-up, which will reassess. So splintage is one part of non-invasive treatment. Physiotherapy, sir, to avoid joint stiffnesses.
Apart from collagenase, any other modalities, experimental ones, which may or may not work?
I don't recollect.
Interferons, colchicine.
Yes, sir.
So coming to the surgical aspect of it,
yes,
what options do we have?
We have needle fasciotomy.
Fasciotomy. Okay. Just enumerate the surgical options, na?
Yes, sir.
Needle, open, fasciotomy,
yes,
fasciectomy,
fasciectomies, then
total fasciectomy, partial
partial,
fasciectomy,
segmental,
extensive.
Yes.
So how do we make a decision? How would you take an incision for this patient if you want to go ahead with a surgical release or fasciotomy for this patient?
So I would take Brunner's incision over the begin with Brunner's incisions over the digit and extend them down onto the palm. If it is involving both the digits, the little and the ring, and on the palm, I would mark the incisions in a way that the flap, the incision over the web space in such a way that the distally web space based flap is formed. And
so Brunner's is typically a zigzag incision.
Incision.
So what was the problem we had in our previous patient of Dupuytren's, which we operated with the current patient which is coming for follow-up?
Yes, sir.
We took a Brunner's incision.
Yes, sir.
So what problem did we have?
So we saw discoloration of the flaps because probably very thin flaps are raised, and the distal placed web space flap was also discolored.
So Brunner's, classically in case of Dupuytren's, our flaps are going to be always thin.
Always.
Why?
Yes. So because the process, the disease pathology is it is very adherent to the skin, the dermis, and in separating for complete excision of the diseased tissue, we need to raise thin flaps so that the diseased tissue lays back and which can be excised.
Okay. So if we were to go back and operate the same patient again, and if we were to take a different incision,
Sir,
apart from Brunner's, is there any other option that we could change our incision and modify it?
we could take the original longitudinal incisions as described by Houston along the cords, and then subsequently close it by giving by converting into a Z-plasties.
So what would be the advantage in that scenario as compared to a Brunner's zigzag incision? I believe that was given by Scoop or Houston? I
Scoop,
don't-
yes.
Scoop.
Scoop said that, yes, Scoop, it's Scoop's operation in which and later on converted into C plastic. The advantage, I would say, sir, we would under vision examine, have.
So the advantage in that scenario would be our flaps would be smaller. The length to width ratio of those flaps, of those Z plus Ts would be smaller because we would be taking a linear incision on this over this area. Na?
Yes, sir.
Instead of taking a typical Z wherein our flaps would be significantly larger, our longitudinal incision is marked first and then we convert it into multiple Zs. So our flaps are going to be smaller and chances of necrosis of those thin flaps are also going to be lesser.
Yes, sir.
Isn't it?
Yes, sir.
So what precautions do we take in the incision? Any pathology of the disease which we need to be aware of, which we need to be careful?
So in cases especially involving the spiral bands, when there is spiral cord in, then in that case while incising, since as the disease progresses and the cord becomes more prominent and the contracture becomes more prominent, the the volar displacement of the neurovascular bundles gets more prominent, and they lie immediately below they would lie immediately below the incision line. So while taking the incision, we should be careful and under magnification.
Right. So this is also especially important when we are doing needle aponeurotomy because it is a blind procedure.
Yes.
And more severe the disease, more chances of the neurovascular pedicles being on the surface and more chances of we being likely to damage it.
Yes.
So now you have opened up the incision, you have identified the neurovascular structures, you have safeguarded it. So how would you proceed with the surgery now?
So once I have safeguarded the neurovascular bundles, I would have separated the diseased tissue, the cord, and I would excise it completely.
Okay. You do a
Fasciectomy. And
so what would be the end point of your excision?
end point would be to achieve complete extension of the finger, since I am doing open fasciectomy.
Okay. So you would be able to do that in the palm. In the digits, if you are not able to do that. Now, in this scenario, we don't have significant contracture of PIP.
Sir.
But let us assume that you also have contracture of the PIP.
Yes.
So in case you are not able to extend the finger completely after doing a fasciectomy, what would be the probable reasons and how would you troubleshoot around them?
So the probable reasons would be being the chronicity of the disease. There would be periarticular adhesions at the joints, and I would look for these adhesions. I would try to break them if required, and volar capsulotomy at the joints would be required.
Okay, and if not, then what would be the last option you have?
Last option would be to do an arthrodesis.
Before that, before committing to something definitive, anything which would probably give you a functional finger with good range of movement.
Excision of the
Yeah, you have tried that, but it is the periarticular adhesions and those are not working. So you could always go for distraction. That would probably gradually release the adhesions, stretch the neurovascular bundles gradually, and give a good outcome. What is a tabletop test and what is the importance of the tabletop test in this patient?
Tabletop test is patient is made to place his hand palm down on the table. He is unable to completely touch down the fingers and his palm together on the table. It denotes that there is certain degree of contracture present. These contractures at the initial time can be noted down, and the angle of contracture and perhaps the height from the table till the apex of the hand can be noted, and these findings
Apex of the MCP.
apex of the MCP, and these findings can be subsequently evaluated if a path of follow-up and conservative management is initially chosen and patient is asked to follow up. Then we can follow up with the subsequent findings and note down the progression, if any, is there any progression or if there is any improvement in the angle. So that would help me in prognosticating and planning treatment and explaining the patient also the course of the disease.
Okay. So